So let me move now into our first session, the root causes of poor maternal health outcomes for Black and Indigenous people. And I'm really delighted that in this session, we have three speakers who can frame this discussion that will be so helpful to draw upon for the next 2 days. They will really call upon what are some of those antecedent factors that create and result in the diverse and negative health outcomes so often experienced by Black and Indigenous people that we really want to eliminate not only now, but into the future. It is a great pleasure for me to introduce to you our first speaker, Dr. Crear-Perry, who is the founder and president of the National Birth Equity Collaborative. Thank you, Dora, for your words of wisdom.
Thank you, Claire, so much. And what an honor it is to be here today with all of you, especially on this beginning Monday morning to start off this conversation about advancing Black maternal health rights and justice. My colleagues there at the National Academies, but also sharing the stage with the brilliance of Monica McLemore and Marina. I'm just so excited. So let's get started. We want to frame the conversation so that the next 2 days we know that we're coming at this not from a deficit model or one that that says that people are broken and can't grow, but really a vision for the future. So MBEC is about 6 years old. And our vision is that all Black mamas, babies, and their villages thrive. So that means really supporting the well-being of all birthing people or the people who have the capacity for birthing, just in case they decide they want to at some point or not, right? And so our core values are radical joy, but the one I really want to highlight today is understanding this relationship around power, because the power that we all have collectively to make sure that those statistics that Dr. Zhao mentioned at the beginning of this conversation end, and that those statistics for the United States move forward are so important. So we're going to use our collective power to push for all people being able to thrive in the future. Next slide, please. So the reason I really wanted to start with this slide and give us some grounding around the timeline of the African-American experience, this comes from Dr. Seeley Jefferson's work, that 86% of the Black experience has been under explicit legal racial oppression, right? So being able to be owned, sold, legally lynched, raped, all those things, 80%, and even segregated by law, couldn't be in the same hospitals, in the same facilities, in the same schools. So we're not gonna fix all this with just being able to vote, right? So passing one law saying you have the ability to vote or saying that you have the ability to even desegregate, that's not going to fix this underlying devaluation, the belief of a hierarchy of human value based upon skin color, based upon gender, based upon religion, based upon immigration status. All of those things deeply impede our ability to thrive as a country and as a world. So undoing this devaluation is really how we're going to get to a future of justice and joy. Next slide, please. So when we started about 6 years ago, we didn't have a definition for birth equity. There were definitions for health equity, equity in general, but not birth equity. So we looked at our mission and our vision and our values, and we said, okay, well, what would birth equity look like? We know many things when we talk about equity, especially inside of healthcare and public health. As an OBGYN, as a former public health official, we say there's going to be this equity where all people are equal, and we've done all these things, and we can hold hands, sing kumbaya, dance off into the sun, and all things are equal. But we know that sometimes you get a few steps forward and then 5, 6, 7 steps backwards. So it's not so much that we're going to get to this equal place, right? And that the people who are today hoarding power and wealth are teaching their grandchildren to hoard power and wealth. So we have to teach our grandchildren to fight for justice and joy. So that means we have to put the assurances in place. That's the policies, big P, like Medicaid expansion, or the policies, little p, like what are your hours? Do you ensure that birthing people or people with the capacity for birthing are able to be seen on the weekends and at night because they have hourly jobs and do not have paid leave because we've not created a policy that allows for that, right? So what are the assurances for the conditions? So it's not people's choices or genetics that cause us to have health inequities, but the conditions that we create in our work and our policies. How do we ensure those conditions apply for optimal births? So we don't want folks just to survive a pregnancy. So thank God I got out of UPenn, I saw Dr. Elizabeth, and I'm done, right? No, we want them to thrive. We want them to say, that was an amazing experience. They valued me. they saw me, they listened to me, right? So optimal births for all people, not just people who have wealth, low resource, homeless, indigenous, everybody should be able to thrive. That means we, us, policymakers, us, providers, we have to be willing to address both racial and social inequities in a sustained effort. So although these 2 days are going to be exciting and important for all of us in this field and this work, we're going to have to sustain this going forward forever. This is not going to go away just because we have this conversation. We're going to have to all work together to ensure it works going forward. Next slide, please. So about 15 years ago, I was the director of maternal and child health for the City of New Orleans Health Department. So if you all know, 15 years ago, what was happening in New Orleans, right? So the president flew by and waved at us from Air Force One. But the World Health Organization actually came to New Orleans. They came in a hotel, and I was a young person in the room taking notes as they were talking about this idea that it wasn't your genes or your choices that cause health disparities, but these things called social determinants of health. Things like having safe and affordable housing, having a quality education, having social connection and safety, feeling safe, having job security. Can you push it again, please, Christy? And those things, not having those things cause you to have unhealthy behaviors, as my colleagues at MPHI, Dr. Cassie and others have talked about, right? Push it again, please. And that makes us have this disparity in the distribution of disease, illness, and well-being, right? So it's not that Black and brown people are broken, indigenous folks are making bad choices, or we have different kidneys or lungs or pelvises, but all of these social determinants of health are causing the distribution of disease, illness, and also well-being, right? So others who have better access are hoarding, are keeping a lot of well-being that we're not having been able to share the prosperity. We have a shared prosperity around the world. What happens to me also happens to you, a belief in that, right? So you see the top of my slide is still empty because although it's been really exciting for the last 15 years for the world, for public health and healthcare to finally stop blaming and shaming individuals, but looking at these social determinants of health, what we haven't had is an honest conversation about where they come from. Why don't we have quality education for all? Why don't we have job security for all, right? We haven't had that conversation yet. Next slide, please. Push it again, And so push it one more time. That's because we have a power and wealth imbalance. Push it again, Christy. And those are things like our labor markets, our housing policy, our social safety net, our social networks, our tax policy. In the US, they have three main root causes. Push it again. And those are racism, push it again, classism, and gender oppression. Now you could add some more, right? My own state of Louisiana, you could definitely add religious fundamentalism. In other systems, you could add casteism, you could add tribalism. But if we don't undo these root causes, next slide, push it again one more time. We will make programs around these social determinants of health, but not undo the harm, the root injury that causes them in the first place. For an example of that, a concrete example would be right now, everyone in healthcare and public health understands that transportation and lack of transportation is a social determinant of health. Everyone knows that. And so if you're in urban America, rural America, suburban America, everywhere we interview birthing people and talk to them about their health, they all discuss this lack of a transportation access, not just to doctor's appointments, but to be able to wash your clothes, right? So in order for us to really improve that, what we currently do is we give people we give people Lyft. I must love WIC. I was a WIC person and gave out WIC. So we give people Lyft and Uber vouchers, which is exciting for us, not to just blame them and say, oh, she missed this appointment, she's so awful. But we're actually saying we need to meet you where we are. Here is a voucher to get to your appointment. But if we really want to undo the root causes, we would acknowledge the history of redlining. We would acknowledge the history of neighborhood covenants. We would understand that segregation was by law. So many of the places in this country that don't have transportation, and we don't have high-speed rail like we should, and we don't have access to free buses, it's because our deep history of segregation and of racism. So that is undoing the root cause and building a real transportation network across the United States, from urban to suburban to rural America, because we shouldn't need a green book to move around. We shouldn't have to worry about sundown towns. These are all reasons that we don't have a real transportation system in this country. To undo that, to improve maternal health, we have to first be truthful about that and then build systems to undo those harms. Next slide, please. So the social determinants of health are the conditions in which people are born, grow, live, work, and age. Most people can quote that. It's been around for 15, 16 years since WHO published this work, but we always ignore, it's like the preamble to the Constitution or the Negro National Anthem. We can sing the first verse, but we mumble the second verses, right? That second sentence is where we get stuck in this work around Black maternal health, any maternal health. We're not talking about that fact that these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local level. So if we're gonna see maternal health outcomes improve, we have to undo these social determinants of health inequities. Next slide, please. So that means as an OBGYN, when you come in to see me and we're talking about maternal health, I say, these are your risk factors. Eclampsia, big word for seizing and having high blood pressure, having cardiac disease or heart disease, having your kidneys to fail. Obesity is the #1 bias in the United States. People come in to get for an earache, and we say you must get your stomach stapled, right? So preconception BMI, chronic conditions, but what about those social risk factors? Who is ensuring that it's not just these clinical risk factors for mortality and morbidity, but things like your air quality? We know that climate change is real. We know that people are dying from heat exhaustion, that increases your risk of birth injury. So who's working on that? Who's ensuring that birthing people have access to decreasing environmental stress? It's food security. How about even something as simple as your employment schedule? Many birthing people cannot make twice a week NSTs, right? If you have an hourly job and no paid leave, and then we blame and shame them for not coming in twice a week to be seen when they're making a choice between $7.25 an hour to feed the children they do have or themselves versus coming in for an NST. Next slide, please. So when we first learned that Black birthing people were dying at 3 to 4 times the rate of their white counterparts, or in places like New York City, 8 to 12 times the rate of their white counterparts, we said, well, we have to get ahead of this narrative, because just like the COVID pandemic, when you see communities of color who are more highly impacted, historically, the narrative has always been to blame and shame us, right? So we knew they were gonna say, of course, Black birthing people are dying. They're so fat, and they don't listen, they're so non-compliant, and they don't go to the doctor, and they don't get married. There's all these single mamas running around not getting married and not going to school. So we got the actual data. We were able to get the actual data, and it showed that Black mothers who are college educated fare worse than women of all races. Even the CDC found 5 times more likely to die within a year of childbirth if we have a college education. Obese women of all races have better birth outcomes than Black women who are normal weight. So we do our little crunchies and our little exercises, and we're still more likely to die. As Serena Williams, we're still more likely not to be seen, not to be valued. We live in the wealthiest neighborhoods, and we're still more likely to have poor outcomes. We move to the gated community. Racism is like, I see you, sis, where you going? Here I come, right? And this last one is really hard for my fellow OBGYNs and I to conceive of, because we believe we are the center of the universe. People just come to the doctor, we could fix all their things. If they just come and get these NSTs, they will be fine. We can check their blood pressure and their urine. Black women, by data, who initiate prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. That's not to say that we shouldn't go to school, or that we shouldn't try to be healthy and eat healthy and exercise, or that we shouldn't try to live in nice neighborhoods, or that we shouldn't go to the doctor. The truth is, we have lots of programs and we do all of these things, and we are still more likely to die. This is our entire public health strategy. So if we leave these 2 days and all we come out with is, if only they would just go to the doctor and exercise and eat more kale, we have lost the point of undoing the structural racism and the inequalities in this country that harm and devalue people of color. So that is the point of this slide, to undo the root causes and no longer blame and shame individuals. Next slide, please. So that means you have to understand what racism is, what the definitions are. I use generally Dr. Kamar Jones's levels of racism: internalized, personally mediated, and institutional. Internalized is something that most Black people know, because if you live in a place that devalues you, you start devaluing yourself. You start thinking, well, I must lighten my skin or not be seen near other Black people because I don't want people to think that I'm broken, right? But it also, if you believe that because you're white, you're supposed to have things, it causes you to vote against Obamacare or vote against Medicaid expansion because that's something for people of color. Meanwhile, your family members are dying from illnesses that they should not die from. Personally mediated is what you think of when I say the term racism, and that's someone calling someone a bad name or calling, and that does happen. It happens in healthcare, and it happens in your facilities and out in your home visiting centers, but it's not the overarching reason why we have poor outcomes. And then the last one, institutional, is really the undergirding of how we decide things like where Medicaid is expanded or not, who's deserving of health, why we tie having to have a job in order to get health to in the first place. Why is your employment tied to your health? Those are structures that we've internalized and institutionalized to believe who's deserving of health and not. Next slide, please. So if we talk about reproduction, we have to talk about reproductive injustice and the history in this country, the history of Lucy, Betsy, and Anarcha, who were 3 Black women who were enslaved, who a plantation doctor by the name of Dr. J. Marion Sims practiced on without anesthesia. And he taught people across the United States that Black people did not feel pain because he did surgeries on them without using anesthesia and they survived them. That narrative of us not feeling pain is still deeply held in medical students and residents and faculty members. Clearly the medical students don't learn it from the air, they learn it from their presenters, from their faculty members, from their deans, from their presidents. So how do we undo this belief that Black people don't feel pain? My own school of Tulane, there was a disease called drapetomania. Dr. Samuel Cartwright said if a slave wanted to escape, they were mentally ill. You could cut off a toe as a treatment for wanting to be free. So I have a t-shirt that says drapetomaniac because I always want to be free, right? And then this really is understanding how eugenics, a belief in stratified reproduction, that some people are deserving of having children and so get invested in for their infertility needs. Other countries who are high income, they provide infertility treatment on public insurance. In this country, we can't even get employer-based insurance to cover infertility treatments. It's something that's only seen for the wealthy. So this idea of who is valuable and who should have children and manipulating through family planning and population control must end. We must really invest in well-being and justice and joy. Next slide, please. And so what would we look like to have respectful maternity care? This is a project we're doing through Robert Wood Johnson with the American College of OBGYN and Johns Hopkins School of Public Health. Next slide, please. What's missing from the care of Black women is their centered voice, validation of experience, and freedom to choose and be informed. Black women need respectful care that is free of implicit and explicit bias. It is the provider's responsibility to address those biases. To address the issue of maternal mortality, we need care that originates from, is defined by, Black women-led organizations, practitioners, and community members. This is Jessica Roach, who's on the board of the Black Mamas Matter Alliance with me. She's a nurse, she's a doula, she's a public health person, and she's also one of my favorite people. Next slide, please. So global respectful maternity care is a term that's used globally. Usually in low-income countries, we act as if having wealth makes you magically respectful. As a non-centered community member in the United States and any other place, you can tell you that having money and wealth in a nation does not make you magically respectful. All right, so we said, well, what would it look like to have respectful maternity care in the United States? Next slide, please. We interviewed Black birthing people across the United States to say, what would it look like to have respectful maternity care? Next slide, please. These are the themes that they told us. They want accountability. They want empathy. They want safety. You can't have a quality improvement safety without undoing racism. You're never going to get to improving outcomes for Black, brown, and indigenous people unless you undo the devaluation of them. That's part of your safety protocol. They want trust, and not trust in the way that we talk about it. We hear it a lot right now during the COVID. Why don't we trust the vaccine? Why don't we trust the healthcare system? Do we trust patients? Every time you write non-compliant in a chart, what do you think that implies to a patient? What if you could never write the word non-compliant? What would you have to do instead to figure out what's happening in their lives, to address their needs, to decide that they are deserving of care and of empathy and of safety, right? And during COVID-19, this even been highlighted, the lack of transparency, the lack of having information and communication. These are the things that people deserve and want for respectful care. Next slide, please. This is our cycle to respectful care. It was just released in the International Journal of Environmental IJPHR, something like that, along with our colleagues at the American College of OBGYN. But at the core of it is your oath. It could be your Hippocratic oath, or as a Black physician, my Imhotep oath, or as a nurse, your Nightingale oath. Whatever core, what holds you, what values do you hold? And one of them is also valuing Blackness, because it has been devalued for so long. You have to have that as a core belief. You have to first wake up, and that might be that you watched the murder of George Floyd and you said, man, this racism is too intense. Or it might be that your boss says, I looked at our numbers at our hospital and Black birthing people are not getting their pain addressed. They're not getting their hemorrhage addressed. They are dying when they should not. So we're gonna wake up. So the first step is you getting ready as an individual, not jumping out to community, you're gonna fix people, but unlearning the things that you've learned that are harmful. I was taught in medical school, there were 3 biological races. Mongoloid, Caucasoid, and Negroid. I have to unlearn that. I have to unlearn the harm that was taught to me by powerful institutions. So you have to start with yourself, getting ready and unlearning these things. Then you can work with other providers. Then you can create change in the community. And you see it's a cycle and not a pyramid, because you're not going to check it off, finish 2 days, finish a webinar, finish the implicit bias training, and now you're culturally confident. You have to be humble, constantly unlearning things that we've all learned. Right now I'm working on decolonizing myself, because as a Black person in the Americas, I'm deeply colonized. So how do we decolonize the things that we think about, how we work in this world? Next slide, please. This is my last slide. It's important. My favorite book is Ibram Kendi's Stamped from the Beginning, The History of Racist Ideas in America. And it's pertinent for us to unlearn so much of the history that we learned that was incorrect. And for me, with the story, he follows 5 people in the book, and one of them is Abraham Lincoln. And the story that resonates with me is near the end of his presidency, 5 people came to the White House and they said, hey guys, I have some money. You can go back to Liberia or to Panama, but you have to leave. And they said to him, but guys, and so President Lincoln said, no, here's some money, take your people and go back. And they said, well, we want to stay. We've been here for 250 years, building all this for free. We think we want to stay in the United States. And he said, but guys, if you leave, the war would end and we can move forward. Because the truth is, although Abraham Lincoln was a kind and moral man, and he believed slavery was bad, he also believed Black people were broken and we'd served our purpose and we needed to go back where we came from. And he was a segregationist. So if you are in this work and you were working on maternal health and you believe that the people you're helping are broken and your job is to save them, we don't need you in this work. We need to know that we're not broken, that policies and there have been cultural beliefs that have been trying to break us. But we all want to be actively anti-racist. So that means we have to see each other as all fully human and that we all are deserving of justice and joy. Thank you.
Thank you so much for the incredible remarks. I have to say, as a Latina, when I saw your first name, it's Hoya, which means jewel.
Yes.
So you are a jewel to all of us for having presented that.